Okay, so I'll get started. We don't have much time. I want to introduce the speakers on comorbidity that don't need much introduction. The first speaker on atopic dermatitis is Eric Simpson. Dr. Simpson is a professor of dermatology, and he heads the clinical trial unit at Oregon Health and Science University. He specializes in all aspects of dermatology, but as you know, he has a special interest in atopic dermatitis and inflammatory skin diseases in both adults and children. For psoriasis, our speaker is Joel Gelfand. Dr. Gelfand is a tenured professor of dermatology and epidemiology at UPenn, University of Pennsylvania, Perelman School of Medicine. He is also vice chair of clinical research and medical director. Of the clinical trial unit, and director of the Psoriasis and Phototherapy Treatment Center, and the founding director of the Patient-Centered Outcome Research Center at Penn Graduate Epidemiology Master Degree Program. So,
yeah, we're just chit-chatting over here. All right, so let's see, Eric and I are going to do his old school a little bit. I'm going to start talking about comorbidities and psoriasis, and Eric will talk about an atopic derm.
And we're going to switch off every sentence, actually.
Every sentence, right, exactly. Then we don't want to give you too much whiplash, but we try to have an organized framework of what we're discussing, and you'll see the comparisons and contrastions as we go through it. My disclosure slide, I should say, is in your handout. I do consulting for some companies that make products related to psoriasis and release some grants for them.
And you okay if I sit down?
Yeah, please enjoy yourself, yes. Okay, so this is sort of the paradigm that we've been studying for the last well over a decade now, which is to bring other talks into this. To develop a phenotype of psoriasis, you need to have environmental exposures and genetic exposures. And so many of these, the way we think about it as epidemiologists, is how these relate to both psoriasis and cardiovascular disease, being shared risk factors. And then when you have psoriasis, you're exposed to chronic inflammation, certain types of treatment, and a burden of disease. And all these different factors, be the risk factors, the pathophysiology, or these other factors, could commingle to promote comorbidity, or in this case, we'll talk about cardiovascular disease as a model. Now, this is sort of discussed by some of the other speakers, but this is a really interesting heat map from Nature that came out, and I'll try and use the mouse if it'll pop up here. It won't. Kind of pointer. So basically, the more closely two conditions are related genetically by these expression studies, the more close they appear on this graph. And so psoriasis is in the middle here, and you see atopic dermatitis at the edge over here, with atopic derm, at least genetically, commingling with asthma, allergy, primary sclerosing cholangitis, migraine. Psoriasis is more in the middle here, closer to Crohn's disease, ankylosing spondylitis, and certain metabolic conditions of cholesterol, which sort of puts some context into some of the at least cardiometabolic comorbidities we see in psoriasis. And so there's a couple of fundamental things we need to think about in psoriasis. One is the immune abnormalities are profound. You have to have billions of T cells infiltrating the skin to maintain this phenotype in people with psoriasis. And the disease is largely uncontrolled. In Junko's talk, she mentioned that roughly 90% of patients who have severe psoriasis, 10% body surface area, are essentially on no treatment whatsoever. From older work done in the field, what we know is that the more severe your skin disease is, the more likely you are to have increases in systemic inflammation, be it C-reactive protein, ICAM1, and serum amyloid A. And these three are all known to be cardiovascular risk markers in healthy controls. So again, suggesting shared pathways. And this leads to the unifying theory, if you will, that inflammation may be a common pathway to a variety of diseases, including atherosclerosis, obesity, and insulin resistance. So this is now a summary slide of about 10 years of work. And essentially we're using large population-based data sets, hundreds of thousands of patients essentially, looking at the rates of cardiovascular events, controlling for traditional cardiovascular risk factors available us in EMR data, so smoking status, BMI, diagnosis of diabetes, hypertension, hyperlipidemia. And what you'll see is that people have more mild disease, they didn't receive systemic therapies or phototherapy, for example, they have small associations with these major cardiovascular outcomes. And in those who have more severe disease, they got phototherapy or systemic agents, they have more clinically significant rates of these outcomes. And the clinical significance is that people with moderate severe psoriasis die about 5 years younger than they should based on their risk factors for mortality. And think of it as a dermatologist, a person with moderate severe psoriasis is about 30 times more likely to develop a major cardiovascular event, somehow attributable to their skin disease, as opposed to their measured risk factors, than they are to develop a melanoma. So we all know melanoma is a really important problem for our patients. This just puts in perspective for you how important cardiovascular disease is for patients with psoriasis. Now, I think as Eric's talk will allude to, this work's been going on for a longer period of time in the psoriasis field. The first reports of psoriasis and diabetes date back to the late 1800s, actually, in the German literature. But we focus on cardiovascular disease. There's hundreds of papers being published a year now on this topic, over 9 meta-analyses, all largely confirming our initial findings in this field, that more severe psoriasis is associated with higher rates of cardiovascular events. Now, more recently, what we've tried to do is understand how psoriasis compares to another major Th1 disease, if you will, rheumatoid arthritis, in the same data sets, large UK population-based data. And what you'll see is something specific in psoriatic disease that promotes diabetes, independent of body mass index, that you don't see in people with RA. And then those getting systemic therapies, largely methotrexate in both populations here, those with psoriasis have fairly similar rates of major cardiovascular events like death, and even slightly higher rates of all-cause mortality. And again, this is independent of simultaneous analysis of risk factors for these events. And so this led to some investigators in the rheum literature suggest that severe psoriasis should be considered in the cardiovascular risk score. And so more recently, what we try to do is move past using treatment patterns as markers of disease severity to directly asking the GPs to categorize how bad the skin disease activity is. And so using these simple National Psoriasis Foundation categorizations, what we see is that as you go from mild to moderate to more severe disease based on body surface area, you have a dose response and the odds of having major cardiovascular disease at baseline in this cohort study we're doing. And this is a large study. It's 9,000 patients with psoriasis, 90,000 controls, and very high response rates. The GP response rate was close to 95%. This was a system set up for medical research, and they're compensated for this. Bringing back some of the concepts from the earlier talks, Jim Kruger on the left side of the screen is showing that metabolic and cardiovascular risk gene expression is much elevated in patients with psoriasis compared to normal patients. That some of these proteins circulate systemically, so like renin, for example, which we know promotes hypertension. And so what we conclude from this is that the skin itself may drive distal comorbidity. And then this is work by Nicole Ward's group, seminal paper here, looking at a mouse model of psoriasis. When the gene contract is expressed just in the skin, these mice eventually develop aortic disease and thrombosis, suggesting again proof of concept that this chronic psoriasis-like inflammation in the skin of a mouse could ultimately result in distal comorbidities. And I'll briefly allude to this work, this will be talked about more at this upcoming meeting, which is that we've been using imaging biomarkers as a way of looking at systemic inflammation in psoriasis. So in 18 FDG PET CTs, it's felt that radiolabeled glucose is selectively taken up by CD68 macrophages. And this is an interesting biomarker because it's known to be predictive of cardiovascular events. When we're looking at the aorta, we know that it improves with therapies known to lower risk of cardiovascular disease like statins, and increasingly in early phase studies, it's using it as a surrogate for drug discovery to look for agents that may lower cardiovascular risk. And so working collaboratively with Nehal Mehta, who's now at NHLBI, what we've shown is, one is if you have psoriasis, you have increased aortic inflammation equivalent to being about 10 years older than you are chronologically, independent of your risk factors. And then more recently, what Nehal's group has shown here is that as your PASI score goes up, severity of your skin disease goes up, that your aortic inflammation goes up in direct correlation with that, independent of all the detailed measurements of cardiovascular risk factors you could do. So at a population level, we could show strong associations with events, cardiovascular mortality, if you will, independent of risk factors we can only measure not so tightly. You know, we sort of know they smoke, but how much do they smoke? We know their BMI, we don't necessarily always have their blood pressure, for example. And in Nehal's cohort, it's not an event study, but very tight control for confounding. So there's been a lot of work rapidly going on in this field. Another group has shown that psoriasis is associated with increased arterial inflammation on these PET CT scans, but also that extends into the subcutaneous fat. And then another group showed that the adipose under psoriasis plaques expresses microRNAs that modulate lipid metabolism. So there may be an epidermal adipose connection here that brings cardiometabolic disease together. Nicole Ward's group has done more work suggesting that IL-6 is the main mediator of psoriasiform associated thrombosis. Bringing back genetics into this, Daphne Glabman's group, looking at a patient cohort of people with psoriatic disease, found that those who had HLA-CW6, they had the highest burden of atherosclerosis. And then finally, there's some initial comparative studies going on now, and these are shown on your slides here, suggesting that at least cardiometabolic disease seems to be more prevalent in people with psoriasis compared to people with atopic dermatitis. And another study showing people who are admitted for presumably severe atopic dermatitis or severe psoriasis, that those who have severe psoriasis tend to have even higher rates of mortality in atopic dermatitis. And these are sort of initial sort of comparative studies that we could talk about a little bit more during the talk. All right, so this has led to the fundamental question for our field, which is really, is psoriasis an elective disease to treat, or is this a disease that 90% of the patient population can be untreated, and that's something that we should not be concerned about. And so here, the most robust data, I believe, is in observational research, large cohorts of studies predominantly in people with rheumatoid arthritis, but also with psoriasis, showing fairly strong cardioprotective effects on MACE events in people getting TNF inhibitors compared to other strategies. Somewhat similar findings, not as strong in methotrexate, but largely people do think that methotrexate is cardioprotective as well. So our model has then been doing a series of rigorous randomized controlled placebo trials, comparing things like adalimumab or phototherapy compared to placebo, or ustekinumab or secukinumab, or more recently we're launching a study with apremilast to see what these therapies do beyond the skin. Will they lower the signal in the aorta compared to placebo? And then we should all be aware in this room about the cardiovascular inflammation reduction trial, the CERT trial being done by Paul Ridker. This is a large RCT of methotrexate looking at placebo control, looking at its ability to lower the risk of vascular disease. Not in people who have RA or psoriasis, but people who just have a high risk of cardiovascular disease. So this will be the first definitive proof of concept that just suppressing inflammatory activity lowers vascular disease risk, if in fact that's what the study finds. And I think this will have a paradigm shift for how we think about methotrexate. Because if it not only could improve your skin and your joints, but it lowers your risk of cardiovascular mortality, that would really change the risk-benefit profile of that drug. So I'm just going to sum up fairly quickly. I think in our field, the most prominently associated comorbidities at this point in time are cardiovascular disease, metabolic disease, of course, psoriatic arthritis, mood conditions, Crohn's disease, and cutaneous T-cell lymphoma of the skin. And this is work done by Zelma Chiesa, who's in the audience, looking again large population-based data sets, looking at the association of these different conditions. And what she shows is essentially that CTCL, you have about a 9-fold higher rate of getting that diagnosis if essentially you've seen a dermatologist for bad psoriasis and will put on systemic agents of phototherapy. So it's something as clinicians we need to be on the lookout for, either for misdiagnosis or progression of disease. There's a lot of emerging work in this field: sleep apnea, NASH, COPD. Like, how could COPD be related to psoriasis? Well, IL-17 is a master regulator of both of those tissues, so it may be more than just confounding effects. It may be a direct biological link. And I also mentioned that I think despite all the progress we've had in psoriasis comorbidities research, we're still in the infancy also. So we published in the BMJ about 3 years ago now that if you have increasing severity of skin disease, you have an increase in prevalence of moderate to advanced chronic kidney disease. Again, independent of these risk factors, they're more likely to end up going on dialysis. Other investigators have then shown higher rates of renal-related mortality. So this shows you that only in this decade alone, we're just getting the first studies looking at major associations with major organs like the kidney. Nothing was really done there. So for clinicians, what we should know about is the implications are we need to screen our patients for psoriatic arthritis. We need to determine the impact of their disease and their physical and emotional health. These are things that guide treatment decisions. We need to educate our patients about cardiovascular risk and screen or refer for known risk factors. And when using immune modulating treatment, we should be referring for age-appropriate cancer screening. and instituting age-appropriate vaccinations. So like in my own practice, we give the flu shot to our patients. We actually give pneumonia vaccines to our patients as well, because we're trying to lower the risk of infectious complications. And unfortunately, someone was saying we're not doing a great job in this area. This is UK data showing that as the body surface area goes up, the odds of having your blood pressure adequately controlled is going down. And then more recent work was published a few months ago showing again in UK that when they brought people with psoriasis in from the community, they found that over a third of them had a high risk for cardiovascular disease they previously did not know about. So there's a lot of under-screening going out there and a lot of under-management cardiovascular risk factors. So we need to do at least what we know works for our patients to achieve better outcomes. And that's a lot of information. Conveniently, we have a JAD CME, Junko Takeshi's first author on this, one of our earlier speakers, summarizing virtually everything you need to know about psoriasis and comorbidity in this month's issue. So with that, I'm going to turn it over to my left coast person here and give it over to Eric. And I think I left you at least 35 seconds.
Thank you. I asked Joel if he wanted to stand up here together, and he said, "I'll stand right behind you like Trump did to Hillary."
Oh, sweet.
Okay, so my disclosures, I've been a consultant investigator for Regeneron and Sanofi. I'll mention one slide regarding dupilumab, and I won't be talking about any off-label uses of medications. So just quick outline, I'll talk about conceptual overview. Joel lent me his slide free of charge, his overview of comorbidities and causal direction. I'll talk more about atopic march. There's less data regarding cardiovascular disease, so I won't focus on that as much. We'll talk about well-established as well as emerging comorbidities, and then I'll try to sprinkle in some clinical implications along the way. Okay, so this is Joel's slide, but converted atopic dermatitis. So you can think about direct causal relationships with comorbid diseases. So for example, in atopic dermatitis, you'd have these environmental and genetic risk factors coming together to give a child with atopic dermatitis with some potentially mediating factors such as disease severity, IgE sensitization, skin barrier dysfunction, Th2 inflammation. And then you can imagine that or picture that going to or leading to comorbid atopic diseases, so for example, asthma or food allergy. Okay, so this sounds good, it sounds clean, however, it's probably not reality. So it doesn't happen this way in all patients, and it definitely doesn't happen in this common atopic march description where eczema starts first, then food allergy, followed by wheeze or asthma and allergic rhinitis later on. So the only way you can kind of dissect what's really happening, what is the true atopic march, is kind of looking at cohort studies. So this is Danielle Belgrave's work looking at a couple different UK cohorts and trying to figure out, well, what does start first? What are these different trajectories of the atopic march? And so what she actually found using machine learning, Bayesian statistics, is that there's a whole bunch of atopic marches. And you can see here that, let's see, where's my, okay. So here's the traditional atopic march. Only 3% of patients will go through that traditional where you start with this red line of eczema, followed by asthma, later on by allergic rhinitis. There's a lot of other things that happen. You get eczema only in this latent class. You can get transient wheeze. You can get rhinitis only. You can get persistent eczema followed by rhinitis. So there's lots of different atopic trajectories. There's not one true atopic march. So if you try to model atopic dermatitis into one of these kind of accepted models of comorbidity, so it doesn't fall into a direct causation model very well, strictly. It's not really associated risk factors that give you that comorbid disease, strictly. So it's more like atopic dermatitis itself. It's more the heterogeneity model of comorbidity, meaning that risk factors you can have the same risk factors for asthma or atopic dermatitis or food allergy. And then I would add a couple arrows to this that you can also have the direct causation, so it's even more heterogeneous than these simplified models, of course. So how do we study this then? How do we discover new therapeutics, new preventive strategies if things are so heterogeneous? And so I came across this paper just recently. This was published in the JECI maybe this month, last month, and I didn't really know about this group. It's a group called Mechanisms of the Development of Allergy And they were trying to study that very concept using a systems biology approach. So I think to answer some of these questions, I just bring this to your attention. I don't understand most of the methodology of systems biology, to be totally honest, but I think this is what it's going to take. It's going to take integrating multiple birth cohorts. It's going to take integrating clinical data, patient data, epidemiological data, omics data to try to figure out what exactly is going on. Where do we intervene for patients? This European group also consulted with the NIH and NIAID as well for a discussion of their hypotheses. And I have to admit, it's pretty asthma-driven, it's pretty IgE-driven, and so some of these findings, I think, like I was talking to Dr. Bieber, that as clinicians, we kind of knew a lot of this was true, but I think it's exciting research that I think you should follow, and I think we need more dermatologists on this list. It's mainly allergists, so I think we can bring something to the table. So here are the main findings of that group. So allergic comorbidity clustered together, we knew that, also called multimorbidity. But they did find a novel finding that polysensitization versus monosensitization was very important for predicting that multimorbidity. Like we dermatologists and allergists who treat eczema know, about 38% of the comorbidity that cluster these groups are related to IgE, but IgE is not necessary and it's not the predominant causal mechanism of all these atopic diseases. So we knew that from therapeutic data of blocking IgE. The proteomic networking analyses data look like Th2 signaling is pretty important, especially for these multi-morbidity cases. So in summary, basically causal arrows go everywhere, but Th2-driven signals and Th2 dysfunction is pretty darn important for these diseases that may start at different times. Okay, so let me just finish with one more atopic comorbidity, which is food allergy. So we know that atopic dermatitis is a really important risk factor for the development of true IgE-mediated placebo oral challenged diagnosed food allergy. And Carsten Flohr has done some nice work and some systematic reviews to show that. Jonathan and I showed that more severe eczema predicts that you're more likely to get food allergy and actually more severe food allergy. So there's this direct relationship between eczema severity and food allergy. But the overall prevalence within children with atopic dermatitis is probably around 15–16%. We don't know what the prevalence of true food allergy is in adults with atopic dermatitis. So it's been reported all over the place, between 30%, 50%. We just did a clinical sample from 5 different universities that show it's probably somewhere around 10%. There didn't seem to be any increase in prevalence or dramatic increase in prevalence that was statistically significant between mild and moderate to severe in adults. But we need more work on the role of food allergy in adult atopic dermatitis. One thing that's important to note in terms of causation is that the skin barrier may be a site of IgE sensitization. So there's really nice mouse models. If you put ovalbumin on the back of a mouse, abrade the skin, you get very high IgE production from that protein through the skin. And you can actually mimic asthma-like phenotypes if you then challenge with that allergen through the respiratory route. Dr. Hanifin, my mentor, likes to say skin's a high IgE output system. And this has been reported multiple times, multiple different mouse models. Most recently with peanut allergen, you actually don't have to abrade the skin to get this response. It kind of peanut allergen acts like its own adjuvant. Okay, so is there evidence that this is actually happening in humans? So there's some, it's indirect, but for example, a big predictor of latex allergy is irritant hand eczema, back when latex gloves were more commonly used. Predictor of peanut allergy, IgE mediated, is the use of peanut oil. This is back when there was peanut protein still in peanut oil. There's not anymore, especially not in the United States. That was some nice work from Gideon Lack, which is most of this work. Environmental levels of peanuts, a peanut dust in the environment correlates with food allergy to peanut, and filagra mutations and the presence of atopic dermatitis can intensify that effect of environmental peanut exposure. So quick clinical guidance, you have to address it. If you don't address it and they don't address it, they're still thinking that food allergy is causing their eczema. So I recommend addressing it. I say it's associated with the disease, but it's not the cause of the disease. when patients bring in these lists of IgEs and unfortunately now IgG testing to food allergy, I say 50% of the American population has a positive test, and positive test does not mean allergy. There's been 9 randomized controlled trials looking at food restriction in atopic dermatitis. Only one showed benefit, and that was basically patients who actually had urticarial responses to egg. If they removed egg, their eczema got better. And then, so overall, the evidence of allergen avoidance in terms of food is very weak in my perspective, and likely promotes allergy. So why do I say this? Because of the data from the LEAP study. So if you expose children early to peanut around 4 to 6 months, they have a dramatically reduced type 1 allergy at age 5 to peanut. And so trying to translate this, though, to the population-based level is difficult. And so this was there's some food allergy guideline addendum that was just published in the JACI, basically recommending feeding infants who are at high risk peanut early. But I'd say the controversial point is, is whether you need to refer these patients to an allergist for peanut testing prior to exposure. And so there was a really nice JAMA opinion piece just published, and they brought up some points. How do you define severe eczema? They're worried about moderate or even mild disease, patients with mild disease getting referred to allergists for testing. So this is really going to tax the healthcare system, and is it really necessary when there's really been no reports that first exposure to peanut or to any food has been related to anaphylaxis in less than 12 months of life. Okay, moving on to other common associations with atopic dermatitis. So Staphylococcus aureus, as you know, colonization infection is a big problem, but even in psoriasis, there's colonization rates that have been published in this meta-analysis between 3 and 64%. Dr. Silverberg has some nice studies recently published to show that infections in psoriasis are actually more common than we would think, either both cutaneous and non-cutaneous. So pathogenic mechanisms for infection are both barrier-mediated as well as inflammatory-mediated. I don't know which one's more important. And I'm going to skip some of our work. We're looking at barrier dysfunction and staph colonization. And again, I think the take-home for that story is that it's unclear. We know that patients with staph colonization have more Th2 activity systemically, as measured by TARC, and also barrier dysfunction. But we don't know what's causing staph colonization. Is it the staph colonization driving severity and barrier dysfunction, or is it vice versa? So clinical guidance, antibiotics for uninfected eczema doesn't help. That's what the systematic reviews confirm. There's pretty good evidence that control of eczema does improve infection rates. We limit antibiotic use to 5 days of use. There's some in vitro data to support that and reducing resistance. Consider bleach baths for recurring infections, and then reculture. So Dr. Hannafin showed that you can reverse your MRSA status to MSSA. Okay, so just a couple slides on emerging comorbidities. How much time do I have? Okay. So we showed that the prevalence of mental health comorbidities are increased in atopic dermatitis. So in children, ADHD, anxiety, depression. Jonathan Silverberg has shown the same thing, and many others have shown the same thing in adults as well. Treatment, it's unclear where the causal direction, but interestingly enough, treatment with dupilumab, for example, this is data from SOLO-1 and SOLO-2, their phase 3 trials most recently published, that if you take the subset of patients who have HAD scores, Hospital Anxiety and Depression Scale, and if you take the subset of patients who qualify for clinical anxiety or depression, and you treat them with this Th2 blockade, you can see that at week 16, up to 30 to 40% of them then no longer qualify as having clinical anxiety or depression. Statistically significant over placebo. So controlling inflammation, controlling itch can seemingly have a nice positive effect on mental health comorbidity. Okay, so I'm gonna jump to the summary slide. So the take home for the next 2 slides is basically it's unclear whether cardiovascular risk is increased in atopic dermatitis. It does not appear to be as significant as in psoriasis, and that's 2 large population-based studies have shown that. And other emerging comorbidities that are somewhat controversial are obesity, alopecia areata, vitiligo, rheumatoid arthritis, and cancer has been inconsistent. Okay, so these are our combined conclusions. I made them short, and then Joel made them much longer. So I'm kind of a simple thinker. He's a complex thinker. So cardiovascular and metabolic disease are well-established comorbidities in psoriasis, but the risk in AD is still being clarified. Cohort studies with measurement of disease severity, confounding, and design elements to address bias may help determine the directionality and causation. Treatment of the inflammatory disease may improve the risk of future comorbidity, but rigorous placebo-controlled RCTs are lacking, except with this guy. And then comparison of disease outcomes in psoriasis and atopic dermatitis should be motivated by gaining a better understanding of the immune pathways, but proper control groups and appropriate study design, you know where that came from, analysis and interpretation are necessary to avoid erroneous conclusions. Hey, I'm right on 15 minutes. More thorough questioning about risk factors for comorbidities and making appropriate referrals is optimal for the total care of your patient. Thank you very much.
So maybe we'd like to discuss a little bit more. I guess we have a few minutes for discussion. So, Eric, I guess I want to think about some of the paradigms in psoriasis and how you may bring them into atopic dermatitis. So one of our big things has been having combined clinics with rheumatologists. We really recognize that as dermatologists, it can be challenging for us to really identify they truly have PSA. It's hard to definitively make that diagnosis, and then if the cases are complicated, we really want that treated by the rheumatologist, even though our drugs often work for that disease. In the field of atopic eczema, is it moving that way? Do people work more commonly with allergists and pulmonologists?
Yeah, I mean, so there are many kind of centers of excellence. Jonathan has one of them, many across Europe that take that take care of the total patient. I think it's just difficult logistically and financially to keep these eczema schools and eczema centers afloat. Mm-hmm. This may be inappropriate, but I talked to Dr. Liang about what are the key essential things that you would need to make such a center so we can take better care of our patients. He said if you don't skin prick test, and if you don't have an allergist, it's going to be really hard to keep the whole thing afloat. And not saying that we don't skin prick test our patients, but there's complex logistical issues to consider. I'm interested in what are the most important features of those eczema schools that really help the patient, and I think some of those studies still need to come.
So, but do you think as a dermatologist, the role is to ask patients about their asthma control, ask patients about seasonal allergies and hay fever and the control of that, and then refer, or is it, I'm looking at the skin and I'm going to treat that and we move on?
No, I agree with you. So I think appropriate referrals is really important. I think it's a slippery slope, though, if we notice these comorbidities, and then what is our role for screening and treatment? So I try not to screen patients too aggressively if I'm not willing to address the problem. Mm-hmm. So if a patient comes in with and other symptoms of asthma are uncontrolled, or they have undiagnosed depression, anxiety, I definitely refer to the specialist. And so I would be interested to hear your take. You showed that slide saying that patients or that dermatologists aren't screening or
right,
for.
Right.
So what is the role of the dermatologist? Where do you think that line should be drawn?
Yeah, well, I think the secret of caring for the patient is caring for the patient. And I think in psoriasis, maybe even worse in your field where your patients tend to be younger than ours. So we're probably the only doctor taking care of them. And they see us as their doctors. So they come in assuming that if we don't tell them anything's wrong, they assume everything's fine. And so all the prednisone we have to give them or potent topical steroids systemically, topically for a long time, they may be getting hypertension or other problems that are commingling why they think they're still relatively young and healthy. So I do think there's an opportunity there for just ensuring the patients are getting this basic routine medical care that they would get ordinarily. The things I think about a little bit also is about the complexity of choosing treatments. And so in psoriatic disease, some of our therapies work for the joints but don't work for the skin. And sometimes the other way around. And so we often have to be mindful about that when working with our colleagues. Will that play out in atopic derm? Will treatments that work for the skin not work for the lungs systemically, or the other way around?
I mean, like some of that networking data I showed you, TH2 is pretty important, and we know that, for example, dupilumab can treat treat asthma and atopic dermatitis. So there will be some added value with some of our biologics, but we're still in infancy compared to you guys. So.
Great. All right, well, thank you so much for your attention. We'll move on to the next part of the discussion.